The issue really is the squeeze between what we're getting paid and what our costs are doing. And the shortage of healthcare workers, I think it hits the smaller hospitals harder.
Welcome to Rural Health Today. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. Well, it is a great pleasure to be in the studio today with one of my closest colleagues and friends, Tim Johnson, who is the Chief Executive Officer of Eaton Rapids Medical Center. We're going to talk a little bit more about what your hospital does. It is a critical access hospital, but you do more than what most critical access hospitals do. You have a phenomenal team up there and an amazing reputation in that community. We're going to talk a little bit about that, Tim, but you know, obviously for our listeners, there's always, this idea of, big healthcare. And we have used this platform to accentuate how essential rural hospitals are to the infrastructure of healthcare in general. In other words, when we think about the University of Michigan or Mayo Clinic, they get their patients from us. Typically, our patients will first be diagnosed by us. They're seen by us. They're even cared for by us until a point we can no longer give care, right? Because of the acuity. So I want to talk a little bit about your role. You have a dynamic background, both in finance and at the C-suite level as an executive officer and as the chief of an organization, which is very difficult in today's time. So what we want to do is start by allowing our listeners to get to know you just a little bit more. So why don't you give us some background of who you are, where you've been, your education, what you do at Eaton Rapids today, and what you've done before.
Yeah, well, thank you, JJ. And thank you for having me on as well. I really appreciate this.
This is your second time on a podcast.
Well, actually, third time.
Is it third on podcast?
Maybe the third time will be the charm.
Well, this is your third time, isn't it? That's right. And you've done some Facebook Lives with us before.
Yes,
you always do a great job. As just a preamble to this conversation, Tim's always saying, well, I'm better at finance and talking. He blows it out of the water. No. You do. You kill it because you speak from your heart. And I think that's what's important.
Yeah, thank you.
So, there's a purpose and a passion behind what you do. What is it? What brought you to Eaton Rapids? And give a little indication about what you do.
Great. Well, yes, thank you. And, my path to being a hospital CEO, it's maybe not quite as crazy as yours.
Mine's wild. Mine's wild. It is.
But mine's kind of, first of all, I don't think anybody grows up thinking they want to be a hospital
Never
CEO.
said that when I was out in the playground, as arresting people. And, I never was thinking about taking care of them like that. Right?
But then, and even the TV shows, we're usually the bad guys.
We're the bad guys.
Right. Nobody wants to be a hospital CEO.
Who wants to do that, right? You have to yell at those doctors, Exactly.
But for me growing up, actually, It's a Wonderful Life was one of my favorite movies.
Okay.
It still is.
It doesn't surprise me.
Nope. And then
it doesn't.
I actually grew up wanting to be a bank president in a small town.
Really?
That was my dream. I wanted to be
I wanted
to be George Bailey. I wanted to be the CEO of a savings and loan in
now,
a small
that's not
town.
the guy that took the money away. No. What was his name?
President.
That was the guy in the wheelchair.
Right.
He was a bad guy. But that's not the bank president. Potter.
Right.
But so you don't want to be Potter.
No,
you wanted to be the bank president. Okay.
Right, yes.
All right.
The president.
So you're thinking, I want to go into finance.
Yes. So I did. So I went to Michigan State after high school and I got a degree in accounting. I actually took banking classes as electives.
Oh, my goodness.
And I'm thinking that, and then after college, I land my dream job. I'm working for KPMG, auditing banks, which is going to get me into the banking field. But my wife at the time, who we had gotten married way too young. But,
that's a whole other podcast.
That's another story. But she graduated with an RN degree and went to work at one of the large Lansing hospitals.
Okay, I did not know that.
Yep.
Okay,
so,
all right. So she's a third shift RN.
Yep.
And now you get introduced probably to healthcare, right?
That's exactly it.
Yeah.
So actually what I would do is, this is probably illegal, but I think the statute of limitations has run out.
Yeah.
But I would sneak in Saturday nights in the middle of the night and hang out at the nurse's station.
Oh, yeah.
I just
Observe.
wanted to see my wife and hang out. And
yeah.
So, but man, they would get busy. So they taught me how to answer the call lights.
Oh, is that right?
So Saturday nights, I would answer those call
like
lights.
a volunteer. That's awesome.
Yeah. And they, that's when I realized that I loved this. I loved the hospitals. This is what I wanted to do.
Wow.
So I ended up switching.
What a story.
Yep. So I went from auditing banks I got into auditing hospitals. And then I ended up taking a job at a large hospital systems in their finance area.
So when you say auditing, you were at an auditing firm that would do reviews of their annual finances and those type of things for our listeners to understand that.
Yes.
So then you transitioned over into just a different field, which is healthcare.
Yep.
Start auditing. But I mean, auditing a hospital, a little bit different than delivering meals on the floor, right? So when did you realize, like, okay, I don't want to just audit anymore? When did you realize I want to do more in healthcare?
Part of that was led by the birth of my son. I didn't want to be on the road anymore.
Yeah.
And especially with a wife that was working nights.
Right.
So I needed a job where I could just be at home every day.
Yeah.
And so then that's when I took the job at a large hospital in the finance area.
So you're doing just entry-level finance work, right, at a hospital?
Actually, I hired in at the manager level.
You hired in as a manager, and so then you start doing that. And at what point did you wake up and go, I really like this? Did it take a while, or did you from the beginning?
No, I always
right from the
liked it.
beginning.
Always from the beginning.
Yeah.
Yes.
And from there, it was a journey, right?
Yep.
Did you ever imagine that you'd be in a chief executive officer seat?
No,
honestly,
isn't that funny how that works?
Maybe you thought of a CFO, but talk to us, because you have a remarkable background, how you got to the role you're in now as the chief leader of your organization.
Well, so I came down to Eaton Rapids to be their CFO.
Okay.
And then I did that for 10 years.
Yeah.
And then that's when our CEO retired.
Yeah.
And that's when they just
let's say year 9, you're a CFO, right? You're getting ready to complete your 10th year, you're getting ready to enter your 10th year. You find out at whatever time the CEO is going to retire. Did you ever at one point even think about that could be a transition for you?
Not at first, but I was just very, very fortunate to work for Jack Denton, who he'd been the CEO at a couple different hospitals. He was my CEO at the time. He's the one that brought me in as CFO, and he had a lot of experience as being a hospital CEO, and he had that background. And I was just very fortunate to be able to work with him and learn from him.
Yeah. So a mentor probably your best mentor in healthcare, I would assume.
Absolutely. And I feel like I just carried on his legacy is what I've been able to do. And he's still in the Rotary Club with me.
Is he really?
I saw him this
incredible
morning.
is that?
Yeah.
That's incredible.
I always joke and I always tell everybody, he taught me everything he knows about running a hospital. It took 15 minutes. It was well worth it.
Well, my predecessor had a great saying. Duke Anderson always said, ex-CEO should be exiled or hung on the front lawn of the hospital. That was his belief, because he's like, I'm getting out of your way. Yeah. And there is some nobility in doing it on your own. But if it's great if you've got a great mentorship and a partnership like I had with mine, it makes the transition so much easier.
Yes.
We actually hired my predecessor for about 1.5 years after he left, because we wanted the connection. Mm-hmm. It always feels good when you leave on those terms, doesn't it?
Yep. Sure does.
So you transitioned from CFO to CEO. Now, please don't tell me they made you do both jobs for a while.
No, actually.
Okay, good.
For briefly.
All right, but wasn't long.
Yeah, no, it was not wrong.
Because you cannot do both of those jobs satisfactorily as one guy or gal. So then you start as CEO. What year did you begin? Do you recall?
So it was 2009.
Yeah, 2009. It's been that long.
The end of 2009.
That's incredible.
Isn't it?
So 2009, you take the reins. Now at that time, let's talk a little bit about what Eaton Rapids looked like. Because critical access, talk to us about what Eaton Rapids is, if you would. For a listener that maybe in Texas doesn't even know what a critical access is, what does it mean? Go through what critical access means and then talk about your system, if you would.
Sure. Keep in mind, our hospital is very small, much smaller than your hospital. Mm-hmm. And critical access hospitals, it's a designation that Medicare came up with for very small hospitals, the smallest hospitals. Mm-hmm. And just because of economy of scales, it really puts us at a disadvantage. And they recognize that. So as long as you're a very small hospital, you meet the parameters, then you can get some extra reimbursement from Medicare. And the idea is to, again, just try to keep small hospitals afloat.
And is it just reimbursement on Medicare, right?
Yes.
That's the only uplift that you get?
Yeah.
And is it a percentage of cost, or how do they?
Yes.
Okay, so it's a percentage of cost. And disproportionate share, though, of population, or no? Does that factor in? None? So you get but there's also a lot of things you can't do, though, as a critical access, right?
Yeah, there's some things
you can't have OB, right?
No, you can have OB.
You can have OB.
Yeah, most don't.
Most don't.
Again, it's just the economy of scales.
Right. Beds are limited.
Beds are limited. You're
To how
limited
many?
to 25. It's the
25.
maximum number of beds.
All right.
Your average length of stay is limited.
Yeah.
They really want you
Monitor
to
it.
focus on being just a primary care
Yeah.
type facility. Yeah.
So when you talk about bed utilization, when you say 25 beds, is that the entire system? So in other words, can you operate a SNF, skilled nursing facility?
You
Does that
could.
count
So that
against
would be
it?
separate.
That'd
right.
be separate.
As far as
So it's
acute care
inpatient,
bed.
acute care.
Right. It would be 25.
Do you have
We're at
25
20.
beds?
We're at 20.
You're at 20?
Yep.
Now, just as a point of reference, are you full?
No, we're typically not full, but
Right.
as you know, the trend has been
Correct.
that you're not inpatient anymore.
We're not
So
either.
they make it so hard
Very
to be
hard.
considered an inpatient. So
Yeah.
we do have a lot of observation. We do a lot
Yeah.
of recovery.
Yep.
So the unit might be full,
Yeah.
but it's not inpatient
Yeah.
patients. Yes.
So critical access, you started as a critical access, you're still a critical access, but you didn't have a lot of the services back in 2009 that you have now. And I know this for a fact because recently you took one of the best surgeons away from Jackson County, Dr. Ekbo, and now he is in a partnership and a collaborative, I believe, with you and employed by you. And you're doing a phenomenal job in the Jackson market. Congratulations, by the way.
Oh,
I did text you once and said, good luck, because it's tough and you have succeeded and done very well. The surgeon you chose has an amazing clinical reputation, business acumen, but that's one example of how you thought outside the box of we have to reimagine healthcare. Because I'm assuming, and maybe you can talk about this, if you were to start in 2009, just keep stagnant, would you be here today if you were stagnant?
Oh, no. Yeah. You have to continue to grow, look for ways to grow, look for ways to additional revenue.
How have you done that, Tim? Can you talk to our listeners a little bit? So we have, let's just say, we know we have a wide audience, and it ranges from CEOs at big systems that listen to me, believe it or not, little systems, critical access, even primary care offices. So the CEO that's listening today that really needs some help, like how do we sustain in this market with growth? Why don't you talk to us about how you've done it?
Well,
give a couple examples.
One, orthopedics, like you mentioned. We also we have a neurosurgeon, so we're very lucky that surgeon. And and it's interesting that surgeons just prefer to work at smaller hospitals.
I'm finding that to be the case.
Yes.
Yeah. I just hired my full-time neurosurgeon. He starts January 1st.
Great.
Yeah.
Yep.
And he worked at a big system.
Yep.
And he has been here about a year, not working for me. He will in January. But he said it's night and day difference.
Yeah.
Between what we get, what we give, what we receive at a small hospital compared to a big system.
I got a great example of that.
Please.
So we had a surgeon from a bigger city decided that he was not happy with that system. So he came to us to do surgery. And shortly after he started, I'm driving home from work and I get this call on my phone. I look down and it's him. And as you know, when you're the hospital CEO and you get a call from the surgeon in the evening, it's usually not
It's
a good
not good.
thing.
It's never good.
It's not. But in this time, I answer the phone and he said, Tim, I just wanted to tell you how much I enjoy doing surgery at your hospital.
Wow.
And he said, I was at the end of my career. I was going to retire, but I think I'm going to work longer just because I enjoy working at your hospital.
Now, at what point did you steer off the road, hit an animal, and pinch
Hit
yourself
the
to say,
tree.
is this
Is he
real?
calling to tell me how much better
Because
he
then the
looks?
second is usually, can I ask for a pay raise, right? But none of that happened. It was all, he just enjoyed working.
Yeah. And what he commented is he said that my patients do better in your hospital than they did in the big system.
Isn't that amazing?
And
The
he said
care, the individualized care.
Right. He said it's the care they get from the nursing staff's better. He said that he gave the example of our pharmacist tries to make it a mission of theirs to talk to every single inpatient and ask
do the
them.
same rounding
They
absolutely
just want to say, is there any questions about your medications, anything I can help you with? And he just gave some other examples of why his patients did better in the small hospital than they did the large hospital.
Tim, it was one of the things that I loved to do in my previous role as a chief operating officer. And one of the things I got to do is round on the floors. There would be nothing more I'd love to do in my role to do that today. I just can't.
I know.
It's sad. I mean, we just are so overwhelmed with the political dynamics that we're facing. We'll talk about that. The dynamics we're facing with growth, the community, fighting government and the payments with payers, negotiating contracts. I mean, all of these things that we do in the background truly occupies us 18 to 20 hours a day.
Yep.
I remember you and I had an enlightening conversation at a pizza place not too long ago.
Yeah.
And you said something to me as I was a new CEO, you were a veteran CEO, but you said something to me that really has stuck. And one of the things you said was, JJ, I really never understood why my boss took so many vacations.
Yeah.
You're like, I just didn't understand it until I got in the position and realizing the importance of taking at least one a year of rejuvenation. And I never took vacations. In fact, I haven't had one in 3 years, and that's to the detriment of me and all the surrounding areas of my life. But at the end of the day, I still reflect on that as a wake-up call that I do need to take time to stop because it is so overwhelming. And the perspective that we have as a CEO, much different than COO, much different than CNO.
It is.
It is truly
that pressure.
Yeah.
It's that pressure.
And there's a saying, to whom much has been given, it's a Bible phrase, much is required. And we've been given a lot of responsibility, but we're required to give a lot.
Absolutely.
And another phrase not associated with the Bible, but heavy is, the head that wears the crown. And we give consideration to the fact that it's a lot of responsibility. That stuck with me because the importance of work-life balance. We hear a lot about that today, don't we?
We sure do.
Surgeons, employees want work-life balance. We have to balance that with staffing ratios and all of those things. So you've done a remarkable job at doing that, and your vision of growth has been incredible. So today we're talking with one of my best friends in the industry, a colleague, Tim Johnson, and we're talking about the challenges of the CEO in the C-suite today. And we're facing drastic funding cuts, policies that threaten healthcare sustainability, and really a country that has been gradually losing its trust in the field of healthcare right now in science. Right now, we're faced with an all-out assault. And that assault is coming from the federal government of, do we even trust science? Do we trust health? And we're not going to get into too much politics today, but I'm going to tell you right now, it's made our jobs even more difficult because as I lecture at places across the county and country, as I speak all over, I'm challenged constantly of such things as vaccines are bad, JJ. We would have never said that 15 years ago, Tim. The epidemics, the pandemics, you name the demic, it is a result of, unfortunately, individuals that are not well educated with understanding the health sciences. And when we move away from science, and remember, I'm a minister, I'm also a Republican, I'll say it on here, and I'm telling you, we still have to stick to science. And the problem is we're facing a lot of headwinds today with this issue. And so it is a pleasure to have you here in the studio to share some of these issues and lessons you've learned as a CEO throughout the years, far greater experience than even I have. And today we're going to talk about how the support of our communities is so important, navigating increasing political landscapes is just imperative, and of course, what all this has to do with rural health. So, Tim, I want to start by asking you another question. And we call your hospital, I think it's ERMC, right?
Yep.
So Eaton Rapids Medical Center, right? But it's a hospital doing business. As you look at the needs of your community, as a CEO, and another CEO may be listening in state X, how do you prioritize what the community needs over what you can actually deliver? What mechanism do you have in place to know if what you're doing is even right?
Yeah, I'll tell you, that is tough. It's very tough having that priority. But you're absolutely right. Just to back up a little bit about the trust of the community.
Please.
And again, I'm sure your hospital started like ours. It was the community got together.
Oh, yeah.
They raised the funds.
110 years ago, they raised the funds.
Wow.
They brought food in.
Yeah.
Go to our website. There's an amazing story of it, but it started the same way.
Yeah, I have the notes about the bake sales they had, the dances. That's so. And I love the fact that we're both independent hospitals.
Yes, we are.
And we're still owned by our communities.
We
the
are.
People that raised the money to start our hospital still
live
own
there.
it. Yes.
Yeah, generations later.
Yes.
Still the same families.
Yep.
That brought canned goods to support the patients.
Yep.
Bed linens. It's a remarkable story. And we started in 1915.
Wow.
We're celebrating 110 years.
That's amazing.
It's incredible.
It is.
It's absolutely incredible.
And so rare now. Unfortunately,
It is.
it used to be all the hospitals were that way.
Absolutely.
And now most of them are part of large systems.
They are.
Yep.
Very few of us left. But let's talk about why that is, right?
So then, it's interesting when I just happened to be watching the news. This was years ago when the hospital in Albion closed.
Yeah.
And they were interviewing the CEO, and being a hospital CEO, I was kind of interested to see what he had to say, why they were closing. And I expected him to talk about, labor costs. I expected him to talk about drug costs, about cuts in reimbursement and the payments. And there's so many people you can blame, but he only gave one reason. He said, the reason we're closing our doors is we lost the trust of our community. That's why we're closing our doors. Yes.
That's powerful. And that's usually what happens.
Yes.
There's a, we'll call a steerage issue where the patients will go to other facilities because they trust those facilities more.
Yep.
Now, you and I have been benefactors of individuals that haven't been happy with their community hospital, and they actually come to us.
Yep.
But when that changes, it's game over for hospitals.
Absolutely.
Now that is in light of the situation that happened in Albion. Now today the headwinds you'd have to agree, are much stronger.
Yes.
Than we even faced. I think that's been 18 years, 15 years ago, whenever that was. The headwinds today are far greater. Let's talk first about trust. So when you think about trust, you've built the trust in your community. And that's for a hospital that has been around for 100 years like us, 110 years. Some legends carry on, right? Stories about how grandmother came in for, a ingrown toenail and, we took her liver. I mean, there's so many stories that none of them are even true, and those that are true have been passed down from generation. They're just so exaggerated. But we have to live with that, right? And that's something in reputation management that we always fight. In small health systems, you and I are the first to hear about problems, right?
Oh, yeah.
How many people texted you this past 2 weeks? Patients. Probably got a couple, didn't you?
Yeah.
Saying,
Emails,
delayed
phone calls,
emails, text message. There was a delay in my read. Why can't I get in sooner? How come this happened? Why is my bill this much? And we're connected. I'm assuring you right now and our listeners, hospital system CEOs are probably not getting those messages.
Yeah,
right?
I don't know if you've gotten this one yet. I got this one last week. Somebody was angry that their physician wouldn't prescribe Ozempic.
Oh, Ozempic. Absolutely.
Yes. And
big time.
And it's like, nope, they don't meet the criteria. It's cut and dry. But guess what? That's our fault.
It's our fault.
Right.
It's our fault. Huge issues that we deal with on a daily basis. But because we're connected, and just like you saw your mentor this morning, you're going to run into people each and every day. And so reputation management's a big issue. Legacy is a big issue. You've done a remarkable job at that. But, talk to us a little bit about some of the headwinds you're facing right now, though, as a hospital. You can even talk as an industry as well. But let's start with the hospital level. And, what are your challenges at Eaton Rapids? And then what do you see as a challenge, in our industry?
Well, the issue really is the squeeze between what we're getting paid and what our costs are doing.
Yeah.
And it's the shortage of healthcare workers is just really tough. I think it hits the smaller hospitals harder. We don't have the resources to offer the pay that the big systems do.
I think we're down to 15 travelers here. But if you look at 15 travelers, do you know what that does to your bottom line?
Yeah.
At $70, $80, $90 an hour?
Yep.
It's not sustainable, Tim.
Yep.
But let's talk about the pipeline,
so then
right?
Well, I
Where's
don't know
that
about
at?
you, but sometimes we call to get a traveling nurse and we're told we got nothing.
We have nothing.
No, that we don't have.
There's
anybody we
nothing
can send you.
available.
Those holidays, those certain days.
And these are companies that used to hound us all the time, remember?
Oh, yeah.
We'd delete their emails,
right,
they'd be texting us like, do we have coverage for you?
Right.
And then the pandemic.
Yes.
People started to realize they wanted work-life balance.
Yep.
And many of them exited the industry.
And it's tough. Being a nurse it's tough.
It's one of the toughest jobs around.
So that squeeze between what we're getting paid. I don't know about you, but a lot of times we'd rather have our own staff. So we basically have to auction off positions. So we give you another $100 a shift when you come in. Well, they give you another $200, $300.
It's hard.
Sometimes we go to $1,000 for a nurse to pick up one shift when we get desperate.
Yeah.
Do we get paid any more from the insurance
Absolutely
companies
not.
for taking care of those patients?
Absolutely not. No. Those headwinds are significant.
Yes.
Because labor force is really, in many cases, it's driving how many beds you can fill. For me, I've had to shut down half of my skilled nursing before because I don't have enough CNAs.
Yeah.
So I had closed down for months half of my beds. Well, I still have all the costs associated with that,
Sure
right?
do.
Still paying everybody, still turning the lights on, but I couldn't put patients in beds because I did not have enough CNAs. I'm not talking about nurses, certified nursing assistants.
Yep.
This is after starting schools that we've ran, sponsoring, paying for the education, nothing. It's a talent pipeline issue that we have right now in this country. and it's not just impacting Michigan, you or I. If you look behind you, there's a picture up to the top. That picture displays something back from the early 1900s of a group of nurses that were graduate nurses that trained and were educated at Hillsville Hospital. This is on the front steps of our lawn. I would say there's probably close to 24 nurses there.
Yeah.
This is what we used to do in healthcare, right? We were training our nurses. Then we gave it over to the universities to do and the colleges. And what they did is they created a wide door, but a very narrow back door. And a lot of people were excluded from the program. And people were very frustrated. They couldn't get in. The program only had so many seats. We've kind of done it to ourselves. And then we get into the crisis of the management of the pandemic. And then now we have a shortage. How are you solving the shortage? Because I just saw not too long ago a post from you awarding a young lady a scholarship. You have a program in place?
Yeah.
How many applicants?
I don't think we have any scholarship winners still at our hospital today.
Yeah, it's amazing, isn't it? We give out a free tuition. We give out full tuition up to, I think it's $65,000. Okay?
Oh, yeah.
We, historically, when I started here back in 2010, we would have 20, 30 students would apply. Last year, we had 2 applicants.
Oh, yeah.
2 applicants.
We're seeing the same thing.
When they hire in after their school, they work 4 or 5 months, they get their experience. Another hospital hires them and pays us the education costs back because they're gone.
Yeah, I couldn't believe when you told me that story. It's
happening.
Yeah.
It's happening.
But that's
because
all the hospitals are desperate.
They're desperate.
Desperate.
And you and I can't offer sign-on bonus. Are you offering $50,000 sign-on bonuses?
No.
Our colleagues are, 30, 40, 50. We can never do that.
No.
And I say it's a slap in the face of my nurse that's been working here, like in that lower picture, for 30 years.
Yeah.
Doris Worley's been here for 58 years of her career. Okay. And guess what? We're not giving her any more money. Why would I bring a new nurse in to give them $30,000, $40,000, $50,000 and not recognize the equity of the nurses that are working here? So this is what we're facing in the industry. So you have those headwinds, right? Locally, staffing. What other issues are you facing locally?
I'm sure you're seeing it as well. The cost of the inputs, just drug costs, 20% a year.
20%.
That is just insane.
Yeah. But Tim, the pharmaceuticals say that we're the bad guys, right? Right? Trying to talk about 340B, right?
Yeah.
We're going to annihilate.
Right.
We're going to annihilate it on that.
Yeah.
Because we're the bad guys. But drug cost up, implements, cost of supplies, and we haven't even faced the tariffs yet, right?
Yeah.
Technically, it's going to get worse.
It's
going to get worse. So, from a local perspective, though, stronger than ever, I think you are, right? You'd say as a hospital system.
We get, knock on wood here. We're doing okay. We're holding our own.
Yeah.
But there's a lot of unknowns and like you said, a lot of headwinds we're facing. There's no guarantees that's going to go forward.
Let's talk about the headwinds from a national level.
Yeah.
Once you weigh in, I mean, we got a lot that's going on.
Yeah,
what keeps you up at night about this?
The cuts from Medicaid. Here we are talking about how all of our costs are going up so quickly, and yet our payments are going down.
Down.
Yeah, I don't know how they expect to survive. Yeah, I don't know how that's going to work.
I think Laura Apple from MHA. You know Laura
very well.
You served on the MHA board for 9 years. Is that right?
She was also a tennis partner of mine.
No way.
Yeah, we used to play tennis.
I did not know that. It's a great fact to know. I'll have to use that next time. But Laura talked to my board a few months ago and gave the example that when you factor in inflation, okay, Medicare has not given us a raise since the 70s.
Yeah.
When you factor in inflation.
Believe it.
Then you've got the communities like ours with disproportionate share population of Medicaid.
Yep.
Especially in OB, psych, and some other areas that I have. And you see it too, the disproportionate share. Rural communities are traditionally poorer. They have higher incident rates of individuals that are on Medicaid, Medicare, right? Medicare with a supplement of Medicaid. So you see that. But Medicaid, up until the expansion of Medicaid and then the provider tax for Medicaid. So here we are, we're positioning ourselves that we have not had a raise basically because of inflation with Medicare since the 70s. Medicaid, we got nothing until recently with the uplifts that we got under the provider tax.
Yep.
Now what's at stake right now? Well, provider tax.
Right. Yeah, uplift. Yes.
It's going to go away. 2032, it's all gone, practically, the percentage increases that we've enjoyed. But starting in 2027, the scale back of percentage points by any removal of 1% out of my bottom line means I'm in deficit.
Oh, yeah.
Even 1% right now. We're operating a very shoestring margin. I mean, shoestring margin.
Yeah.
To provide the services that we provide. Hospital CEOs, who would have ever thought we'd celebrate breaking even?
I know. Isn't that something?
Because you can't build your infrastructure. You can't reinvest in your people. You can't, but we celebrate when we break even.
Look at being critical access means we're cost reimbursed from Medicare. And actually, it's not even true cost. They kick out some costs, right? And who'd have ever thought that being cost reimbursed was an advantage? And we're just happy.
I look at you jealous.
Because we're getting our full cost
You're getting
back.
your full cost back, which I don't get.
Yep.
I'm jealous.
I know.
You know, and I mean, who would have thought?
What other industry would that be the case? Where
Never.
you celebrate covering your cost?
I know. And for us, even breaking even as a hospital is something to celebrate, because that means you've covered your costs for the year with the rising cost of labor, the rising cost of the travelers, the payers, all the things. But unfortunately, breaking even doesn't provide for a very healthy future.
It sure doesn't.
You can't reinvest in the workforce. You can't reinvest in the industry, infrastructure, you name it, you're challenged. So Tim, how are we going to do it?
Yeah. Let me tell you another story about Medicaid and the cuts that scared me.
Please.
This was a couple of years ago, but every quarter I have all our providers in for lunch and I give them a little update on what's going on at the hospital. And we'd brought in a new nurse practitioner that had come from a clinic that was a Medicaid independent run Medicaid clinic nearby. And she came in, and when she met our orthopedic surgeon, she looked at him and shook his hand and started to cry. And she said that she had a patient that has needed a hip transplant for 8 years, and she could not find an orthopedic surgeon to do it. That would do that. And she said, when I came here, now you were willing to do that surgery.
Unbelievable.
But the thing is, you can't blame the orthopedic surgeons. They have all the cases they want to do.
They do, and then some.
And why would they do the ones that are going to pay them half as much as the other cases?
They wouldn't, not as independents.
So so she could not find anybody willing to do that surgery. And I worry if Medicare continues to cut, Medicaid, are we going to see that at some point in time?
Yeah, the challenge is going to be, Tim, that we will see it. And then the challenge is going to be for us, because we have to provide those services. So in other words, when I hire an orthopedic surgeon, I can't just say I'm not taking Medicaid. Now, an independent can say that.
No, right.
I can't.
Yes, we can't.
So the problem is that you get the disproportionate share. And if Medicaid doesn't even cover the cost of delivering the service, you have to close the service line. And that's exactly what hospitals have done. Coldwater closed obstetrics. They closed several other programs, home care, other programs. Why is that? Because the cost of doing business exceeded the reimbursement.
Yep.
And when you get to that point, it's no different than in the regular market. When you were to go get your oil change, if the guy had to pay more for the service, the labor, and the parts than he charged you, he's not going to be in business very long. And that's the industry we're living in right now.
Yep.
It's costing us more to deliver the service than we're getting paid. And that's a problem. This isn't about how much we pay our doctors, our executives. It has nothing to do with that. It's a drop in the bucket compared to the $140 million a year that comes out of my hospital. It's in other expenses. It's the cost for my implants. It's the OR lights that I need to buy and the booms, which is almost $1 million this year. It's the new chiller I had to buy for $1 million. It's the elevator I'm putting in for $500,000. These are costs that I can't recover those costs if the government doesn't pay me enough to deliver the service. And that's where we're at in healthcare today. The one big beautiful bill, I call it something different than that.
Okay. I think there's a lot of names.
There's a lot of names. It isn't beautiful.
No.
Not
for hospitals, that's for sure.
It isn't.
Yeah.
Not for rural hospitals.
Yeah.
I mean, the big systems may survive, Tim. They may. Because they're going to say at some level, sorry, we're at capacity. We're not taking your patient cells, right?
Yeah.
Sorry, Tim, we don't have. How many times have you, in your ER, when you've tried to transfer somebody, how many times have you been told, we don't have a bed?
All the time.
Every week.
Yeah.
I'm told this.
Yep.
And they board here. It's not necessarily that they don't have a bed.
Right.
You understand
right.
that.
They always call it a bed. But
Right.
It's not. They have lots of beds.
They have lots of beds.
Right. They don't have staff.
They have lots of rooms, but they don't have staff.
Right.
And so they can't meet the needs. So as the hospitals in our communities close, we had Scott Becker on this podcast a few weeks ago. And Scott Becker gave us a very chilling overview of some of the work that his team has done. And part of that is to look at closures in the country. And we've lost 150 hospitals since 2010. But what's even more scarier is what's projected to be lost in the next several years, 800 hospital closures are projected. You can't open an article from Becker's or other leading articles and not see the devastation that's being forecasted for this industry. 800 hospitals closed, all rule gone.
And what does that mean? Look at even today now, there's places in Michigan where it's over an hour ambulance ride to deliver your baby.
Over an hour.
Yeah.
If you can even get the ambulance to deliver the
right.
patient.
Yes.
Because we have ambulance shortages because of all of those cost reimbursements for ambulance services. They're under the same program, getting Medicaid coverage in rural communities. So they go to the county commissioners for a stipend. The county's like, oh, we're not giving you any more money. So they can't increase the pay that they give their employees, which means that they're out of market, which means that no one's going to come work for them, which means they're not running ambulances. There's given times in our community in Hillsdale, we have 2 ambulances. That's it.
Yeah.
That's it. So if you have a heart attack and you have one on a transport already, you got an issue with your community. So as hospitals close across the country, the shift to us is unbelievable. The ones that remain, because we're getting those patients and we have to service those patients, and it's so hard to turn them away. It's so hard.
It is.
Well, why don't you talk to us about what's encouraging for you right now at Eaton Rapids and in the healthcare industry? We need to close on something positive.
So like you said, we're doing okay. And then we were able to secure a $5 million grant from the state of Michigan to do an addition onto the hospital.
So wait a minute. You were one of those funding, you got it through this year?
Yes. So actually it was, in this year's budget.
In October? No.
The last year's budget.
All right, last year's. Yes. So you have until December to spend that, right?
Well, actually 5 years.
Oh, 5 years.
Which is good because
Was it a federal grant?
No, state.
State grant?
Yep.
They gave you 5 years?
Yep.
Wow. And how does that look then? So it was for a new what? What kind of new building?
For new inpatient rooms.
New inpatient rooms.
Now the problem is we have, like I mentioned, we have 20 beds, but we have those in 10 rooms.
Oh, double roomed.
And
patients don't like that.
When we hit COVID, we had all kinds of problems because we couldn't put a COVID patient in with somebody with a hip transplant.
No.
We couldn't put we don't put males with females. So we would max out at about 16.
Yeah.
Is what we typically, that's full for us, is 16 beds. And then otherwise they have to wait in the emergency room or we transfer them out. And the state had some federal COVID money, and I made the case to them, and luckily they were very supportive that they want to help small independent hospitals, and the legislators I talked to all told me that, and we were because of this money that they had, and how
that
they
shifted a little bit since you've had that conversation with them.
Yes.
The mentality is not always there for that, but so you got that passed through.
Yep.
What year are you in now?
So
year 2, year 1?
So we're just finishing up the year 1. Well, we just started year 2. Yes.
So it started year 2.
Yeah, but man, what we found out is just not encouraging. We want to end on positive notes,
no, it's reality.
So
you got the money.
It was 10 years ago right now that Ionia Hospital, which is much bigger than ours, they were able to buy land down the road, and then they built a whole brand new hospital.
Probably for what, 10 million?
Well, 50. But
50
they built it, they equipped it.
Yeah.
50 million covered everything. Now they're telling us 50 million is what it's going to cost us to bump our hospital out, to add 10 rooms and to bump out our surgery. It's going to be 50 million. And
50 million?
They're not even sure it's going to cover it.
So 5 million is a drop in the bucket.
It's a drop in the bucket.
You can get some paint and some drywall, maybe move some things, but that's it.
We've got the tariffs, inflation.
Oh,
the cost of construction has just skyrocketed. And then hospitals, it's just so much more
gonna be
expensive
tripled.
to meet the codes.
HVAC and you name it.
Yep. So that's but the exciting news is we did get that money. We are going to move forward with it's just trying to figure out how we're going to.
So it's going to look different. Yep. Obviously, you had a desire to have a build out.
Yep.
Probably not going to end up with a build out.
Yeah. Well, it's
going to look different.
It's going to it'll look different, but it's going to be more efficient, and it'll help us.
Yeah.
Yep.
You're fortunate to have received the funds because right now it's a fight of our lives.
Yes.
Because there's a lot of misinformation out there about hospitals getting rich, and getting tons of money. Don't forget, listeners, under the One Big Beautiful Bill, hospitals like Hillsdale, collectively, $1 trillion was cut from the budget, and the majority of that funding is on the backs of hospitals, because what it did is it cut the provider tax. And this tax has been in place through every Republican, Democrat president, Republican Congress, Democrat Congress. What they've done is they've said it's gaming the system, it's fraud, it's waste, it's abuse. The federal government should have to pay for it. The respective states should. At the end of the day, this has been going on for decades that we've received an uplift. Michigan decided to participate about a year and a half ago. We finally got an uplift that we should have been getting a long time ago. Got the uplift thanks to MHA and the work that they did to really cover the cost. That's it. Not make money, but cover the cost of delivering service to this population. Yes. But the Congress now is saying, well, listen, you got that rural transformation money.
Yeah, drop in the bucket.
So they took away $1 trillion. They gave back $50 billion. And of the $50 billion, only half can be used, divided among all the states. So $25 billion divided by all the states in the nation. And then it's an application process that the CMS director himself gets to determine if that's a worthy project. But it's only $25 million divided by 5 years. So it's $5 billion per year for every state in the nation. And they took away $1 trillion.
And it's not just for hospitals.
It's not just hospitals.
We have to share it with the other healthcare
We're sharing
entities.
It with others.
So,
mental health services, behavioral, hospitals, rehab hospital. I mean, it's not just acute hospitals. And so you have $5 billion per year divided by the entire country of every state, and their projects that are approved by CMS director. And Dr. Oz has already made it clear that they would not be supplanting any of the funding taken away under the provider tax.
Yep.
So it's new projects, technology, broadband. I don't know if I need broadband if I don't have a hospital. I don't know how much good it's going to do me for telemedicine when I don't even have a system in place. So there's a lot of misinformation that congressional leaders are putting out there about hospitals will be just fine. No, they cut us $1 trillion. Mm-hmm. And you know what, Tim? There's no way to recover from that. There's got to be a change, because if this comes to fruition in the $1 trillion by 2032, you will see, as Scott Becker has even said in this podcast, 800 hospital closures. The impact on those local economies, think about it. We're the third largest employer in our county, second largest in the city. You're probably one of the largest in your county.
We're the second largest.
Second largest. Yeah. Could you imagine?
Yeah.
The economic infrastructure crumbles, jobs gone, not buying cars, not buying houses. It would be devastating. So we've got a chance to tell our congressional elected officials, stop this, have some reform. We've got to look at this differently, because rural hospitals will close across this country.
Yep.
Those congressional districts will get smaller because people will move out. No one wants to come to a community that has no health care. Businesses don't want to relocate there. We saw that in Albany, Michigan, right?
Yep.
College enrollment will suffer. I'm not going to send my kids to a college that doesn't have any health care. And the list goes on and on. So significant challenges. But Tim, you're beating them. You're doing a great job at Eaton Rapids.
JJ.
Thanks for what you do. Well, we appreciate you, your advocacy, all those years, 9 years, I think, at MHA, the work that you did there, plus the advocacy that you're doing each and every day. Thanks for making a difference for rural health.
Thank you, JJ. Thanks for all you're doing. Thank you for having me on.
Absolutely appreciate you and the hard work. Now, before we close, though, I want you to give some sage advice to our listeners. We end our program every week by asking the guest, you know what? There's brand new CEOs listening to this podcast. We know it. What sage advice would you give someone? Maybe it's just a recommendation. We call it a rural health recommendation. Maybe it's just something to rural health. Maybe it's something about themselves personally. What would you say to the new aspiring, maybe it's not even CEO, C-suite leader, that they should do, become, what they should guard, whatever it is? Maybe it's just a tip. What would that be?
I think it's a tip for basically anybody in a rural community. And that's just, you got to be flexible.
Yeah.
And you have to be willing to learn new things, adapt, because when you're in a big city, people specialize.
They do.
And
whether all they do every day.
Yeah. They do surgeries only on left toes.
Yeah, that's it. You'll never do a right toe surgery.
Right.
Yeah.
Yes.
Yeah.
And in small communities, we have to be a master of everything, because we just don't have those experts nearby.
That's
so
true.
You have to be willing to learn new things, try new things.
That's right.
And do it on your own.
That's right. So you heard it directly from Tim Johnson, CEO, Eaton Rapids Medical Center. He's doing a great job up there. And he said, you know what? It's the opportunity. I've never had one day that's the same. Every day is always different in rural healthcare. It really
that makes us great.
Doesn't it, though?
It sure does.
It's so rewarding and so awesome. But Tim, it's been a great pleasure to have you on the program today. We appreciate it. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural healthcare every Monday, wherever you get your podcast. Don't forget to check out the latest updates on resources from Rural Health Today at ruralhealthtoday.com, and make sure you subscribe to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.